everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kan, founder of Being Patient. Today, we're going to talk about why it's so hard to get an Alzheimer's diagnosis. We've heard many stories from all of you about misdiagnosis or how it took several years for you to get diagnosed with Alzheimer's disease. So we thought today we would talk to one of the experts. Joining us today is Dr. Barak Gaster. He's a professor of medicine at the University of Washington, and he's also the director of the Cognition in Primary Care program at the university, where he actually trains doctors to diagnose and improve dementia care. So Barak, thank you so much for joining us.
Yeah, thanks so much for having me.
Okay, let's just start with that we have talked to so many people who have a very difficult time. They say, usually, let's start from the very beginning. Usually it's a diagnosis of MCI. I feel like doctors are much more comfortable saying it's mild cognitive impairment. And a lot of times that reaction is like, oh, phew, it's only MCI. It's not the big A word, right?
Yeah.
Why is that beginning stage hard for doctors to identify? Or maybe it's a case of like wanting to gently break the news that you could be on this path. I mean, what have you found from your research?
Yeah, I mean, I think it's really complicated. It's hard. I think the human brain is really complicated, and when it starts to sort of break down as it does with neurodegenerative diseases like Alzheimer's disease, it's a slow, gradual process that we still are only beginning to understand. And so, we still don't have like easy tools to identify mild cognitive impairment. That diagnosis is really based on cognitive testing and interviewing an observer, and that is still a relatively complex process that especially primary care providers haven't been trained on. Like, so I went to medical school 25 years ago and really did not learn that at all. And so the majority of primary care providers in practice who are on the front lines sort of getting these sort of concerns are often a little bit unsure what to do, and that's what the Cognition Primary Care program is all about. And I think it's also like this is not a surprise to any of your listeners, which is that there is also just so much sort of stigma. This is a very, very psychologically difficult diagnosis to sort of like grapple with. And so I think there's also a hesitation on the part of primary care providers on the front lines to sort of, open up this, very psychologically sort of complex and intense conversation. And so I think I think those are sort of the main barriers I see. Just really the testing and evaluation and diagnosis is a complex process, and there's a lot of psychological overlay that really sort of requires some coaching to get through.
Okay, and I want to maybe take one step back from that first symptoms. I recently scheduled a physical, and we know the gold standard of care is to get a baseline, right? Because everyone's cognition is varied to a certain extent. Everyone's brain works differently. And so you want to understand when you're healthy where your strengths and weaknesses are in order to have some sort of comparative analysis. Would you agree that's gold standard? Get a baseline before something goes wrong?
Yeah. I mean, gold standard is a tricky word. And
Okay. Is it highly
and
recommended?
yeah, and I would really sort of couch it, as kind of following up with what I was just saying, which is that, that to get a baseline is a complicated and time-intensive thing to do. And so there is still not a great, well-established way to get a baseline on everybody. And so
that was actually my coming point, which
yeah.
was I know this from being in this business now and like having Being Patient as a website. And so I went to my doctor and got a physical, and I said, I'd like a baseline assessment. And he kind of laughed, like,
Right. What do you mean?
are you having problems? Do you need to see a neurologist? I'm like, no,
Right.
I don't
No.
have any problems, but I have a mom with Alzheimer's and I want to know what my cognition is while I'm healthy.
Yeah.
But it's impossible to do. I mean, you would have to actively seek that out. And I'm not even sure being a healthy person, an insurance company would pay for me to get a days or several hour baseline assessment, to be
Right.
quite frank.
Yeah. Yeah.
So are there any ways around that? I mean, because that is actually, in my mind, that's a problem. It's not an easy one that anyone's going to solve tomorrow. Is there a way that we can understand without having a major analytic test? Is there a way that we can get our own baselines?
So, I mean, you're bringing up a really, really important issue, which I do see as like, if I were to sort of, call out like, here is the thing that our society really needs, it is a very, very well developed and established and validated 20-minute sort of test that somebody can have. And whether that is done, in a healthcare setting or outside of healthcare setting is, open. And I think there are a lot of companies that are working on developing tests like that. What we use most often in the healthcare setting is the Montreal Cognitive Assessment, or MoCa test, which takes 10, 15 minutes to do and is not something that somebody should be doing on their own. It really does need to be sort of administered by somebody who is used to giving it and used to scoring it. But I think, we definitely need something that is sort of better than the MoCa, that is, ideally going to be digital and automated. And I think there are a lot of companies working on that. And I think that is a real sort of like goal to really get nailed down a good digital cognitive assessment tool that can be used in a 15 to 20-minute way to really assess somebody's cognition. But I think it's just so important to make the real important case that alone is not really a alone enough for diagnosis. Like, you really do need to put together a cognitive assessment together with some input of how somebody is navigating through the world. And in the research world, that's called the informant. But I hate that term because it is just so loaded, and it sounds like you're sort of ratting somebody out. And so I really prefer the term observer. So a close friend, a family member who spends time with somebody and sees how they're navigating through the world. So it's really getting input from that person and putting that together with a cognitive assessment, and then together with an overview of some people's other medical conditions and medications. Those are like the three components that I see as really making up what should be a diagnostic evaluation for mild cognitive impairment.
You raise a really important point, because when I think about the time when my mom was experiencing difficulties and she didn't have a diagnosis, from her reference point, she didn't know anything was wrong. But what we were noticing is her ability for numbers just started to slide. So she forgot the alarm code that we haven't changed in our house since I was a child, or her ATM card got eaten 3 times in 1 week, and that was the alarm. She needs something's not right. But
Right.
from her perspective, she wouldn't have said, I think something's really, I mean, there's some people who have that self-awareness. At that time, though, she was never asking us to go she never said, I think I need to go see someone. It was more
Right.
like we thought something's really wrong. So that's an important point. I mean, there's other people who are extremely self-aware and know, right? That's why it's such a tricky process, because
Absolutely.
everyone's different. You can't apply exactly the same thing.
And a big part of the Cognition primary care program is actually helping primary care to understand what does that self-awareness mean, because I think often when people are, self-aware, they're self-aware of things that are not worrisome. So somebody who is, it's a little bit slower for them to come up with somebody's name, but then they remember it, or they go up the stairs and they can't remember why they went upstairs, but then they go downstairs and then it comes to them. Those are the things that really freak people out, that make people like, oh my God, I'm aware of my slipping cognition, that are normal things that happen with aging. And so really another big part of the Cognition primary care program is giving primary care, like a concrete sense of here are the things that are worrisome changes that are not normal. And those are the things that absolutely really should require somebody to be strongly encouraged to get a cognitive evaluation.
Okay, let's talk a little bit about that because I think that's really important in terms of whether you are experiencing, everyone asks that question at some point. It usually happens around in your 50s or 60s. Is this normal aging? Or oops, I forgot someone, I'm beginning to forget someone's name or whatever. So I think that's an important point to make as you're kind of giving the tools to the general practitioners out there to say, these are warning signs for them to answer that, make that assessment. Is it normal aging or something more serious? What are the exact things that you are putting in that toolkit to say, red flag, this needs to be given more attention?
Yeah, I mean, so for there, the resource that I most point to for that is the document that has been created by the Alzheimer's Association. So their 10 warning signs of Alzheimer's disease is really, really helpful and useful because it gives you both the warning signs and also it gives you a list of things that are sort of less worrisome. And so, what we do for cognition primary care is really give the primary care providers sort of an even more kind of boiled down version of that, of like, here are the 3 really big warning signs that cover the 3 domains of cognition. And then here are the 3 most commonly identified things that people are worried about that are a lot less worrisome.
Can you give us some of those examples? I'm sure people are saying like, what?
Yeah, right. And so, the if I were to pull out the 3 warning signs that are really, really concerning, it is sort of losing short-term memory, which is most often manifested as asking the same question 30 minutes later. And it's not that somebody forgot the answer to it, but they really don't remember that they asked it. And so that, that's something that's not necessarily going to come up in a, baseline cognitive test. But it's something that you really are often going to want to hear from an observer. And so it's asking the same question 30 minutes later. The other is having difficulty completing a complex task that used to be easy for them. And so examples there are like a complex recipe that somebody has done so many times that they barely even need to look at the recipe. They sort of know how to sequence all of the pieces that you need to do to sort of make that dish. But then one day somebody is like, really kind of stuck and unsure how to executively sort of put the sequence, the things together. And then the third is becoming disoriented in a place that they should know well. And so there, the example would be somebody, is on a route that they have taken hundreds of times on their way home, but like one day they stop and they're actually not sure which way to turn. And those are 3 really, really high concern situations that you want to get from an observer, a family member, a close friend, that are really important to put together. You want to hear changes like that together with a lowish score on a cognitive test that is really the key to making a diagnosis of mild cognitive impairment.
As you said, made that list. I think anyone who has had a loved one with Alzheimer's totally knows what you're talking about, right?
Yeah,
Those 3 things have happened to my mom
yeah.
at an earlier stage when we were kind of like, what's going on? So that's really, really helpful. I think too, that's a really, really great to know and helpful to a lot of people. I wanted to ask a question about the MoCa test though, because I mean, and you have clearly stated, okay, the MoCa test is one tool. It's not the whole comprehensive thing. So, but what was interesting about the MoCa test to me was a couple of things. One is it really depended. I just as an experiment gave my mom the MoCa test every day for 2 weeks.
Oh no.
And she had totally different degrees of how well
Yes,
she did, right? So some days she passed, like it was
right.
within the normal range. Other days she flailed. But the one thing that was consistent within those 14 days of giving her the MoCa test was the fact that the clock she could never get 100% right.
Yeah.
And there's something about the clock that makes me think that is a really good indicator because, and it was described to me as well, think about it, it's multi-layered and it's not literal. Like 2:15 is, not 2:15. It's not spelled out. So you have to really think, and you're thinking in different layers and they have different meanings. And it's the same as following a recipe, right? It's like multi-step processes and thinking. So to me, I'm wondering, maybe we don't need the whole MoCa. Maybe it's just the clock,
Right. Although it's also the case that, the neurodegenerative conditions are so complicated, and, and different people will manifest different domains of cognition as having impairment sooner than others. And, and that is the reason why you need more than one domain to really kind of get like a full picture of how somebody's doing. And the other sort of point that you made of how there can be variability from day to day is also so important, and why just like a snapshot baseline is like, it's good. It's not that it, I wouldn't sort of say that we shouldn't be doing that, but we also have to acknowledge that there is that's not the be all and end all, because
Yeah.
somebody can do great on that one day and not great on the other day. And, if they sort of slept poorly the night before, or they took an over-the-counter sleeping aid that is like having some side effect the next morning, it's gonna affect that snapshot test. And so that's why you really need the 360-degree assessment, which should include an observer input and should include an overall look at sort of their other medical conditions that really could be affecting their cognition.
Okay, I want to talk a little bit about misdiagnosis because we hear a ton of these stories. And this is my very unscientific analysis based on conversations now with hundreds of people who have diagnosis. I believe that Lewy body dementia is the most misdiagnosed dementia based on those conversations. Again, not scientific, just my own observation from the stories that we hear. And what's quite astonishing is people will with Lewy body will be living with an Alzheimer's diagnosis because Alzheimer's seems to be the default for dementia because it's the most common, and then find out 3 to 5 years later that in fact it's Lewy body dementia. Is there, I mean, I'm not, we would have to look at the studies and the data. This is just purely my unscientific observations. Have you heard, like, do you think there's truth in that? Like, why
Yeah.
is Lewy body so hard to diagnose? And I mean, in my mind, it seems like it's the most misdiagnosed one.
Yeah, I mean, and for that, I think the framework that that we really focus on for the cognition primary care program is, there's like the top level spectrum of the syndrome of like how somebody's brain is working, and that spectrum goes from normal aging to mild cognitive impairment to dementia, where with dementia, you've lost more than just some short-term memory or some, executive function, trouble doing a complex task, but you're actually losing some independence with basic activities of daily living. So that's the diagnosis of dementia. And so, the diagnosis of mild cognitive impairment and the diagnosis of dementia is relatively straightforward. I mean, ha ha ha, it's still complicated, but you can do that using a cognitive test together with an observer interview, together with an evaluation of somebody's overall sort of medical condition. But then the etiology for mild cognitive impairment or dementia, which is, if somebody is having a neurocognitive degenerative process, is it Alzheimer's disease? Is it frontotemporal disease? Is it Lewy body disease? Is it vascular disease? Is really, really complicated. And I think, really important point to make is that most people with dementia have a mixed form, that there's more than one
Yeah.
thing going on, and that Alzheimer's disease in its pure form is not the most common cause of dementia. And Lewy body disease is for sure a complex determination to make. And that's why one of the most important points that we make for the cognition and primary care training for primary care is to make sure to ask about visual hallucinations, because somebody who's having visual hallucinations early on in the course of their cognitive impairment is at much higher risk of having Lewy body disease. And Lewy body disease definitely has important diagnostic implications for somebody's care. And so we really do sort of call that out as this is a red flag if somebody is having visual hallucinations early in the course of their cognitive impairment, that they really do need to be referred to a specialist sooner, because they do need a more careful evaluation of sort of what is the cause and could it be Lewy body disease. But yeah, it's the which type, what is the etiology for somebody's neurodegeneration is really, really complex. And I really would generally put that in the sort of camp of this is like a specialist evaluation that is, I think the most important thing is to get primary care sort of engaged and capable and confident in making a diagnosis of mild cognitive impairment or dementia. And then what is the etiology for that is often something that is going to be really in the case of in the camp of the specialist. And I would, it's also the case that often specialists are kind of hedging and uncertain. And yeah.
I wanted to bring up this one point. A gentleman who we've interviewed had to go to 7 neurologists to get a Lewy body dementia diagnosis. And why? Because when he ate, what was salty tasted sweet, what was sweet tasted salty. It took Mayo Clinic to diagnose that as a hallucination, which because everyone thinks of hallucinations as people coming out of the walls or, and they're like, no, that's a hallucination. You have Lewy body, because he wasn't experiencing the memory loss. And so it took him the 7th time Mayo finally got it. But 6 neurologists prior to that didn't get it. So, it is a lot more complicated than I think I'm making it seem like it's not black and white. And there are a lot of overlaps, of course, in symptoms. So Michaela is asking a question right now, and she's asking, can a neurologist tell the difference between different types of dementia from brain scans of a living patient? That's a great question.
Yeah. And so, I mean, and I'm not a neurologist. And so, I am, a little bit out on a limb talking about, how does a neurologist sort of differentiate between the different etiologies for neurodegenerative disease. And, I would say, generally speaking, it's not from an MRI or a CT scan of the brain. I mean, that can give you some input, but I think, it's really important to just say that that is a complex diagnostic determination that you generally want to, put many different sources of information into a basket to help you kind of make that overall assessment. And an MRI or CT scan can be a little bit helpful in that, but it's still a complex process.
And also, I mean, if we're talking about identifying biomarkers of Alzheimer's disease like amyloid plaque, you really need a PET scan, right, to really identify that pathology in the brain. You're not going to get it from an MRI. MRI is more diagnosed like atrophy, right? Am I correct in saying that?
Yeah, and again,
You're not the neurologist.
I'm not the neurologist, and so
We're making you uncomfortable.
Yeah.
Sorry.
No, it's just I really would sort of make the point that that evaluation is complicated, and that looking for biomarkers, whether they are imaging biomarkers or blood-based biomarkers, can definitely add some information in terms of what is the etiology of somebody's neurodegeneration. But this is still an evolving and complex area.
Okay, I want to kind of, because we're getting some questions in about like the right way to get diagnosis and everything. So let's flip the script a little bit. And what should people be asking, whether they are experiencing memory loss or their loved one is, when you're going to the primary physician, can you arm us with questions to ask to get a better diagnosis?
Yeah. And so I would say, making sure that I think, what the other big light bulb for primary care providers when we do our training in cognition primary care is that, one of the things that I love about primary care is that often you go to your primary care provider by yourself. and there's a really sort of like a fabulous kind of one-on-one relationship that hopefully sort of builds over, years and years and years of, of trust and relationship building. But once there is the question of how is somebody's brain functioning, it really is like no longer okay to go by yourself. And that it is like I think the world's best dementia expert has trouble doing a good evaluation of somebody for cognition without having that observer, family member, close friend there with them. And
they should probably be interviewed separately and not in front of the person, because we've had this
yeah,
play.
there's an art to that. You can go either way. Don't want to kind of come down on one side or the other of that, because you definitely can't. You can do it with both person and people in the room, and that's often logistically easier to do. But I think so in terms of like what should you sort of like go into that visit with? Number one is the family member or close friend really should go together with the person who people are either the person or those around them are kind of wondering. And the other thing is to come in with sort of a bit of a narrative or description of what is raising the concern. And then the other thing is really like a really clear sense of what are the medications that somebody is taking, especially over-the-counter medications. I think that's like one of the things that is missed the most in a medical evaluation, because the clinician is often going to look at somebody's prescribed medication list and just assume that that's what the person is taking and not be aware of over-the-counter things that they may be taking, like sleeping aids. So I mentioned like, Tylenol PM is probably the most missed over-the-counter medicine that really negatively impacts people's cognition, that people aren't aware of as a problem, that clinicians aren't aware that somebody is taking it. And you can sort of fall into that trap so easily because there's so much in the news about how, oh, you got to get your sort of 8 hours of sleep in order to prevent dementia. And so people take sleeping aids like Tylenol PM, which has the generic form of Benadryl in it, which is diphenhydramine, which is a really, really strong anticholinergic medication that can really sort of negatively affect cognition, especially in people in their 70s and 80s, especially if they're developing early signs of neurocognitive decline, where asking about that medication or coming in sort of with the list of over-the-counter medications somebody is taking is a really important tool as part of that evaluation.
Yeah, that's really, really helpful, actually. And tell me a little bit about the program to educate primary care. Like, how's it going and how do people access that information?
Yeah. And so, so I've been a primary care doctor for 25 years or so. And it was really only about 7 years ago that I really realized that, gee, dementia is the thing that I am sort of flailing with the most. I really didn't feel like I had a good handle on what to do when somebody comes into my office and says that they're worried about their memory. And so for the past 7 years, I've really tried to become an expert on dementia in the primary care setting, including mild cognitive impairment, and so putting the expertise with dementia together with my expertise in primary care to develop a program that's for primary care by primary care of really how to identify, to do a good cognitive evaluation, how to make a diagnosis of mild cognitive impairment or dementia in the primary care setting, and then really how to counsel patients and families about how to make a plan for what does this diagnosis mean and what can we do to really sort of maintain somebody's brain health as best as we can.
Such
So,
important
yes,
work.
yeah. And so we've rolled that out to a large health system in the Puget Sound, Seattle area, and we've now packaged that and are ready to disseminate to other health systems around the country.
That's wonderful. And can people find out? We can post the site. Actually, you have an open website, right? So Katie, my producer, will post that in the comments link so that people can take a look if you're interested. But Barak Gaster, thank you so much for joining us. I found this to be incredibly helpful. And to our audience, if you missed any of this interview, we'll post it on beingpatient.com. Don't forget to sign up for our newsletter because that's when you get to hear about talks like these. But thanks for watching and see you next time.